prevention. With that, I'd like to introduce Georgia Beasley, one of our melanoma surgeons here at Duke, to talk with you a little bit about some of the aspects from the surgeon's perspective.
So it's really a pleasure to be here. As April mentioned, I'm new. I did all my training mostly here at Duke, and then I went to Ohio State. This seems to work better for my fellowship, and now I'm on the faculty. A clap for the Buckeyes. Okay. And so I'm going to kind of talk a little bit today about sort of the evolution of surgery, and I've titled the talk, as soon as it comes up, Less is More, because we're really moving towards less and less surgery for a lot of cancers and melanoma too. And I start out with this quote: "I do not despair of carcinoma being cured somewhere in the future, but this achievement will never be wrought by the knife of a surgeon." And as someone that's trained for 9 years to do this, it's sometimes hard to admit that. And while I think that surgery is very important for early, melanomas, ultimately, it's not gonna be the cure that we're all looking for. And someone said this in 1883, and some people are still kind of playing this out. And imagine myself having to tell my husband and parents, I've trained for 9 years, but my goal is to put myself out of business as a surgeon. So I start with this because it's a very dramatic example in breast cancer, and it's not as dramatic if I show it in melanoma, but back in the early 1900s, we thought the more surgery, the better. So if it comes back, it's because I didn't take enough. So in the early 1900s, they took, for a breast cancer, a whole woman's, the chest wall, everything, because they thought that was going to be the answer, more and more. Whereas today, we do a nipple sparing, skin sparing mastectomy, where they literally just go under the skin and take out the breast tissue, and they do immediate reconstruction. And the person today actually has a better outcome because of the chemotherapy agents, although, again, I have to be careful to admit these things. So it's less surgery, okay? Doing more and more surgery is not the answer. And I show this again because this is Halstead, who's sort of a famous surgeon that started a lot of these things. So he looks at his own data and he says, boy, when the axilla and the neck are involved with cancer, I'm not curing anybody, right? So even though I'm doing these radical surgeries, I'm actually not curing people. And he thought that if they could just figure out how the lymphatics went, that maybe they could decide that the femur was involved and amputate the hip. Okay, so that was sort of the thinking, and this has been the thinking of surgeons, that we could just take more tissue and that will lead to cure. Okay, and now we've been changing that for several years, but this is just to give you a framework of why this thinking kind of went on. So that when good evidence is lacking, we're not doing wrong. The quote is that I took this from is actually wrong, but people they're trying to do more and more because we're hope that we're right. So now to melanoma, and we have data now. So I'm starting with this question first. So just in melanoma, just like breast cancer, if I just keep taking more and more and more, won't that just solve the problem? And so we've had several studies looking at this, and I've highlighted just a few. So what they do is they take someone with melanoma, and they randomize them either to a smaller margin, like a 2-centimeter margin on the top, or a 4-centimeter margin. And what they found was there was no difference in the recurrence rate on the far left. The recurrence rate was 2% no matter what, no matter if you did a little margin or a bigger margin. Same concept as the breast cancer. And then I've just highlighted another study. They looked at 1-centimeter margins, 3-centimeter margins. So it's no different. So just because you want to do a big radical surgery, it's really not helping. You get the same result. So that's margins. So some surgeons, including a very senior, I guess, surgeon, said, well, gee, a lot of my patients are getting disease that comes back in their lymph nodes. So what if I just start taking all the lymph nodes out, right? That's more surgery. I'm doing more and more. If I just take a little more, maybe I can use surgery to cure people. So most of you know we call that a lymphadenectomy, and I've heard commonly it's usually under the arm, axillary, or in the groin, inguinal. And so surgeons started sort of saying, okay, now I'm going to take a little bit of the skin around, and now I'm going to take all the lymph nodes in the area. But it turns out that only about 20% of people actually have metastasis in those lymph nodes, right? So 80% of the people, again, are getting these big surgeries for not a really strong reason. And it puts them at risk for the complications, which a lot of you are probably familiar with, the lymphedema, nerve injury, wound infections, all those kind of things. 80% of the people getting this, it really wasn't helping. So in the early 90s, when I was not even in high school yet, Don Morton, one of the surgeons, came up with the technique of sentinel lymph node biopsy, right? Where rather than take all the lymph nodes in the area, we could map the tumor to just 1 or 2 nodes in that area to minimize doing a whole lymph node dissection. So this is just, again, less for more. You map the tumor, and then you're just taking out the first lymph node along the channel. Most of you might be familiar with this. And then the concept being if that node was positive, then it would reflect that whole basin or that whole area. So again, moving towards less invasive. So this is less invasive, and a lot of studies have basically shown that it's effective in a similar way. So who gets these sentinel node biopsies? I've tried to summarize this because there is some controversial areas, but this is a general rule that we follow. So it does vary. Your risk of having that sentinel node positive varies with the Breslow depth, so how thick the tumor is. So if you're less than 1 millimeter, you only have about a 5% chance. So we typically don't do sentinel nodes on people that have thin melanomas. And then not surprisingly, the thicker your tumor is, the higher of chance that you would have a node involved. So that's the people that we're doing sentinel nodes for, generally are at least 1 millimeter in thickness and higher. And those are just their chances. And for those of you that might have not seen the technique, this is pictures of after we inject the dye, we take some images, and then we also inject some blue dye that help us find that node. And that, again, that's just 1 or 2 nodes and not taking out the whole thing. So now I told you, we already knew that about 20% of people will have a positive node, right? And so the thinking was, okay, well now I do a sentinel node, I've saved the patient that morbidity, but what if it's positive? Should I go back now and then take out all the rest of the lymph nodes in that area, a completion lymphadenectomy? So the problem with that is we started realizing I have a patient, they have a positive sentinel node, I tell them now I'm gonna remove all those nodes, I take them back to the operating room, remove all those nodes, and then I get the pass saying, oh, none of the other nodes had cancer. So then the patient says, well, gee, that seems like maybe we didn't have to do that. Well, they're right. So the next study that we did was, this slide, sorry, this just shows this number here. So if you took a bunch of people that had over 1,000 with sentinel nodes, and they had a positive sentinel node, and then you went and took out all the lymph nodes in that area, only about 12% of them had more nodes that were involved. So do we have to do it or not? So just this summer, actually, a trial that was designed to answer this question, and it's called MSLT2, and you'll hear us refer to that. And there was also a German study called the DCOG study. There were 2 of these studies. So they took everybody that had a positive node, and they randomized them. They said, okay, for this group, we're not going to do any more surgery. And this group will do the standard thing and take you to surgery and take out all the nodes in that area. Okay, so we're just going to compare the groups. Do we have to do more aggressive surgery or don't we? And so this shows they almost had 2,000 people. Half of them got just observation. Half of them got the rest of the nodes removed. Okay, and here are the results summarized. So there's the overall overarching message is there's no survival benefit from doing the big radical surgery or just watching. So that's sort of major, that's very new. That, again, this came out this summer, so that's very new information. So I'll just kind of make the point again. There's no difference. And this is, again, there's all these sub-analyses or whatever, but I just want the take-home message is there was really no difference in survival between just watching people after their node was positive or doing a radical surgery. So the three-year rate of melanoma-specific survival was similar. 86%, 86%, you can't get much more similar than the exact same number. The complications, not surprisingly, for the people that went on to get the radical surgery was about 24% versus only 6% of people that got just a sentinel node biopsy. Now, in all fairness, it won't probably surprise you that the people that do get observation do have a higher risk of it coming back in that nodal basin, in that same area. But when it comes back, we can do surgery kind of at that time, and this study kind of shows we don't really lose much of anything by doing that. So in summary, surgery, I think, is still very important for early stage, for predicting maybe who might need additional therapy. But this large-scale kind of, what I'll call preventative surgery, really has been demonstrated to be unnecessary. And so we're really moving away from that. So if nodes are obviously involved, which I didn't talk about, if we see a patient and they have nodes that you can obviously palpate and feel, and you already know there are cancer in them, that's usually a time we still go ahead and remove them. That kind of makes sense. If they don't have any obvious spread, then we do the sentinel lymph node biopsy, again, based on the tumor thickness. We remove the 1 or 2 nodes that possibly have cancer to help identify patients that might need other therapy. But if the sentinel node is positive, it's okay to closely monitor. And then if the nodes become evident as we're following, then we can do the surgery. I did want to mention one of the research things going on. I'm going to pause there, just let everybody digest that for a second, because I'm really going to shift gears to, you might have heard this on the news. The Brain Tumor Center here has used this modified polio vaccine to treat brain tumors. And one of our projects that we're working on, hopefully within the year, we're going to start treating some melanoma patients with this. And it's going to be more for people with very advanced disease, not the early stage that surgery can cure, but sort of advanced stage disease. And it's basically a oncolytic virus. Many of you might be familiar with TVEC. It's similar, but I don't like to say that because it is different. It's a different virus, and we think it works a little bit differently. So I did just quickly want to highlight that that's one of the main things we have going on here. And so that I can end with that, it might not be cured by my knife, but maybe by my mind, and then I have to say my sophisticated medical oncology colleagues. And I think that was all I had. So thank you very much.